medical microbiology. I work in Bristol, United Kingdom. Bristol is the capital of the Southwest. The city population is around like 500,000, but it's got tertiary centers that serves like 5 million population. We have the Bristol Heart Institute, and basically we do everything except maybe for heart transplantation. So this is a very common theme and scenario, cardiac implantable electronic devices infections. And we see a lot of these cases. Some of them are really complex and some of them are like the straightforward one. And it's always a regular attender in our MDTs and meetings. So I thought it's really important that I do a bit of a run through some of the cases we've seen recently, and a look at the guidelines that are currently in practice around the world. I'm really sorry I did an in-depth review of the Asian guidelines, but some of the guidelines I'll be discussing today are endorsed by Asian and South American societies as well. So we'll give it a go. And I thought at first maybe I'll just go through one of the cases that we've seen recently. So case one is a 70-year-old gentleman who was seen by his GP last year for some night sweats. He has a background of sick sinus syndrome, for which he had a pacemaker inserted in 2007. This pacemaker was changed in 2020, but unfortunately he had an abandoned lead. Previously had an MI and a microdiscectomy operation. He worked as a caretaker at a local school. He was fit and well otherwise, enjoying his life. By the time he was seen by his GP, he had a slightly raised CRP and he had this irritating dry cough that started since December 2022. He was seen by the time when he was seen by his GP, he did a chest X-ray, which looked really unremarkable. So he booked him for a CT scan because he started to get worried about this night sweats and cough. So while he was waiting for the CT scan, he noticed that his weight has been going down steadily and he started to become generally unwell. So they talked to the hematologist who expedited his CT scan, which showed really no signs of malignancy, but it confirmed a subsegmental PE. So he was started on some anticoagulation, and the hematology team at the time recommended that the GP get in touch with the ID team to investigate pyrexia of unknown origin. He first came known to us by 2023, and we see him in our the same day the GP contacted us in our same day emergency care. He was very well on examination. He had no murmurs of note. But we, knowing of the pacemaker, we were suspecting straightforward, we were suspecting infective endocarditis. So we sent 2 sets of blood cultures and booked him for some urgent echo. But because he was clinically well, we sent him home. 3 days later, the blood cultures flagged positive. The first one, I remember, and it was a staph epi. So we decided we'll just maybe ignore it. But then the second one flagged positive as well with staph epidermidis as well. Unfortunately, the bug was faintly growing, so we didn't have any sense at the time, but we thought maybe in view of his pacemaker, this is significant. So we called him back, we admitted him to hospital, and we urgently looked to do a TOE. That TOE happened 2 days later, which is a miracle if you know the NHS, and it showed really no evidence of effective endocarditis. At the time we admitted him, we immediately repeated his blood cultures. And again, all of these now grew a staph epidermidis, and it had a wild type sensitivity profile. Because his TOE didn't show anything, we went ahead and did a CT PET, which showed it didn't really show any avidity around the pacemaker lead, so around his valves, but it showed only an active branching nodule at the base of his right lower lobe, which the radiologist just recommended the nodule follow-up. So at this time, still, our working diagnosis was that this gentleman probably had an implantable cardiac electronic device, infective endocarditis. And it's not a mistake I use the term ICED, IE, while if you note the title of my presentation was CIED. And this is one of the things that as British we have to distinguish ourselves. So the British guidelines usually use the term ICED, implantable cardiac electronic devices. while most of the rest of the world uses the CIED, cardiac implantable electronic devices. Anyway, so because that was a working diagnosis, we treated him empirically, and we started his treatment immediately after that with vancomycin initially, which we then switched to daptomycin because his cultures were positive on the vancomycin, even though clinically he started to improve. He completed 6 weeks of IV antibiotics. These were via OPAT, so we didn't keep him inpatient, and we added PO rifampicin as an adjunct therapy, and his DOACs were switched to warfarin. We were adamant that this is an implantable cardiac device infection, despite the negative TOE and a negative PET scan. While on treatment, he improved clinically. His fever subsided. His blood culture started to become sterile around March 2023, and we saw him in ID clinic after completing treatment. He was absolutely well at the time. I believe that was 2 weeks after he finished his antibiotics, and because he was clinically well, just for completion of workup, we did a repeat blood culture, and boom, that was positive again with a similar staph epi. He remained well. We repeated the echo, or we requested the repeat. We decided at this point we'll give him a PO. We were confused whether we give him a PO suppressive therapy or repeat his IV course or refer him for surgery, although we have no evidence to suggest he has an ongoing device infection. Really, what would you do differently at this stage? Would you do anything differently than what we did? I think before I just go ahead and tell the what happened, I would really be keen to hear of different views. So please let me know if you do anything differently. Yes, Nidal, please go ahead. You're on mute. Do I make you a presenter so you can talk?
Nidal, can you try to unmute yourself?
Yes, I can mute myself.
Yes, please go ahead.
I'm not sure, but maybe I will repeat the echo.
You repeat the echo. So we requested that already. We requested an echo repeat. But in terms of management, would you have done anything differently? Would you not treated him, or do you think treating him was? Can you hear me? Am I heard? Yeah, sorry. Yeah. Okay. So
I think yeah, it's a tough situation. Like the good thing he's clinically doing well, so that might buy you some time. But he clearly, I guess, failed a trial of, a good trial of medical therapy. So and unless you have a clinical site of alternative clinical site of infection, I guess the option would be to remove it, unless it's like really difficult or it is like some sort of complication, then you will need to suppress him for life.
Yeah. I'll have to say clinically he was really well. He was really well. On examination, nothing really remarkable. And we've had the PETs, we've had the TOE. The repeat echo at the time was really negative. Yes, Muhammad Siddiq, go ahead, please. Can you unmute Muhammad? Is he not a panelist? I can't see him. And Fathi, yes. Fathi, can you unmute? Fathi and Muhammad, can you unmute? And are you not able to be panelists?
Thank you. Can you hear me now? Sorry.
Yes, we can hear you. Yes, go ahead.
Yeah, thanks. It's just more of clarification. question. You might say this already in the beginning, but
Yeah.
you said you gave 6 weeks of antibiotics. Is it after the first negative culture, or is it just 6 weeks from the
Yes,
beginning?
the 6 weeks were counted from the negative cultures. Yes.
Okay, and then after 6 weeks, was it daptomycin? So 6 weeks of daptomycin, then he...
So 6 weeks would have been a combination of vanco and dapto. I think he was positive still on the vancomycin, so we switched him to dapto, and then we got a sterile culture, and then we gave him 6 weeks of that.
Okay, thank you.
Thanks. And Fathi?
Yeah. Thank you, Mustafa. Very challenging case.
Yeah.
I believe what he had as a PE might have been a septic emboli, secondary to some sort of endocarditis. Now, the fact that he has grown his staph epi 6 weeks following extensive treatment indicate probably there is a focus. Most likely it is from the heart, but it could also look for extra sites, whether he had disseminated to the bones or somewhere else. So a good PET scan to rule out other focus of infection will also be useful prior to taking the lead out.
Okay. Would you, I mean, we already had a PET scan at the beginning of investigating the source, and that was unremarkable apart from that lung nodule, which he had a CT scan repeat booked already for 3 months. It was avid, but it was very small, and also wouldn't have explained the staph epi. But would you, I would be keen, would you repeat the PET scan after 6 weeks
I
or
would
8
probably
weeks?
repeat the PET scan to look for another focus, and the PET scan also can help you to diagnose an endocarditis. So it will hit both sites.
Thank you very much. Thank you. And we had no consensus amongst ourselves, to be honest. That was I remember discussing in that MDT, and opinions were really varied between repeating various scans and just repeating the course of daptomycin or antibiotics at the time. He had a PIC line of note, and there were the questions for that. Oh, maybe this is just the PIC line now. It's not really actually a true staph epi, but the susceptibility profile just looks similar. Anyway, we decided, because he was really well, pending the echo and more repeat blood cultures, we changed the PIC line and we gave him suppressive PO Septrin or cotrimoxazole. The echo showed a mild AR and moderate TR with no vegetation seen. We asked a lot of, definitely more than 1 or 2 cardiologists, expert cardiologists, to look at the echo and review that again. And all of them they confirmed similar. There were no vegetations, and they were not really enthusiastic about getting another TOE because he had a TOE already at the beginning. We referred him to the surgeons actually for discussion, for consideration of the removal of the lead. And the reason for that is because he had that abandoned lead. And the physicians, the cardiologists, felt that removal, if there is a problem, it will be that abandoned lead. And removal of the system without removing the abandoned lead is unlikely to make much difference. And maybe even if they need to do it, they will have to have the surgeons on board with them. The surgeons were not really keen. So we sent further blood cultures after changing the line. And again, all of the 3 sets just positive. The only change this time was that it became rifampicin resistant. So we restarted the IV daptomycin. And after completion, I think he was halfway through his second course of vancomycin. The physicians admitted him, and the surgeons actually didn't want to remove the system, and they felt it's really technically difficult. They said, okay, you know what, just give him another round of medical treatment, and maybe he will need a major operation. We explained that this is already treatment failure, and this is the end of the round 2 of for this lead infection, even though we don't really have a vegetation seen or a positive PET scan. He just at this point he became bacteremic despite antimicrobials, and the MICs were reassuring. It's not really a susceptibility problem, it's rather a source control problem. And we were checking daptomycin levels, and these were satisfactory and reassuring, but the surgeons were not really, just not keen at all. So the decision was whether he would have a PO antibiotics as long-term suppressive therapy, given that the surgeons are unable to do it. However, one surgeon towards the end of June suggested that we do a repeat TOE. The TOE towards July 2023, he had a worsening TR and a very large vegetation around the pacemaker leads with severe pulmonary hypertension, sorry, not just hypertension. So they admitted him in August 23 for medical device extraction and attempted lead removal. So they removed the system, but they left the abandoned right ventricle, the abandoned lead. They left him. They said they couldn't remove it. It was really heavy fibros into the myocardium, and it's just going to be a massive problem if they attempted to remove it. They were not really sure. The repeat echo post procedure showed that it's still large tricuspid valve mobile structure. The surgeons at this point started to argue that, well, that might not actually be a vegetation, and it's just really a right ventricle abandoned lead, that it is just giving you that shadow on the echo. During his hospital, let's say he's developed really severe hospital-acquired pneumonia with some lower lobe collapse and empyema in the next few days. He pulled somehow recovery of that empyema. The culture was negative. He eventually the patient got frustrated, and he chose that he would just go with antibiotics lifelong and self-discharge. Again, his medical advice. And we haven't heard from him since. I honestly we still don't know what's going on with him. The second case is a 77-year-old lady who she had an April 23 elective pacemaker insertion for sinus node disease, and she had an explantation of an implantable loop recorder. Her past medical history included paroxysmal AF sinus node disease, hypothyroidism, hypertension, arthritis, and a bilateral total hip replacement. 2 months later, she presented with fever and lethargy. Her blood showed electrolyte derangements and acute kidney injury. Her blood cultures grew as Staph aureus. It was a methicillin sensitive that was resistant to penicillin only. She stated a penicillin allergy, and she was really pedantic about it, so we gave her cefazolin. Cefazolin is really hard to get off in the UK. It's not as easy. I know it's a standard of care in the States, but here we use flucloxacillin. Is a standard of care, and cefazolin is expensive and difficult to get hold. So there were some delays initially. Her echo at the time showed a mobile structure attached to the tricuspid valve and a pacing and the pacing lead on the right cusp of the aortic valve, which was suspicious of lead-associated infective endocarditis. Her permanent pacemaker was explanted 3 days after that, and she had an MRI spine because she kept on complaining of severe back pain. That MRI spine showed no evidence of discitis. She had a TOE repeat 2 weeks after explantation of the infected leads, and it showed multilobulated highly mobile mass, which was attached to the posterior leaflet of the tricuspid valve with a small pericardial effusion. She continued on cefazolin. However, 5 weeks later, she developed pleural effusion with lung collapse, and the cultures from that fluid grew Pseudomonas, enrichment culture only. We decided to treat it because her inflammatory markers did not settle at the time, so we switched her to meropenem. She completed 6 weeks of antistaphylococcal antibiotics from the date of explantation of the pacemaker, and then switched to ceftazidime. So we don't think ceftazidime covers Staph aureus. So she had a bridge of meropenem for I believe a week plus to complete the 6 weeks, and then we switched her to ceftazidime to cover for the Pseudomonas only, and she completed 6 weeks further of anti-Pseudomonal antibiotics. Her CRP came down to 60. She was clinically really well, mobilizing with no problems. So she was discharged home with plans for follow-up. She was seen 2 weeks later in clinic with raised inflammatory markers, and repeat blood cultures in clinic again were positive with Staph aureus bacteremia. So we readmitted her for IV antibiotics, and because she still complained of that back pain, we repeated the MRI spine, which showed no evidence of discitis. She had the echo, which showed that previous multilobulated structure on the tricuspid valve has completely resolved now. She had a PET scan, which showed resolution of that empyema, the pseudomonal one. There were some scattered degenerative changes along the spine, which we felt would be the reason why she had back pain, and some diffuse increased uptake across the thyroid, suggestive of multinodular goiter. She did have increased uptake surrounding both hips, which we knew were prosthetic, but no other source was identified. We did a scan of her hip with a plan to aspirate. The pain she had was mainly around the left side, but that was just unremarkable, really. Her right hip, though, showed the thickening of the joint capsule with some joint effusion. We aspirated that joint, and it showed numerous white cells, but negative cultures. Her CRP was static despite antimicrobial therapy, but she remained clinically really well. She was then referred to the orthopedic surgeons for further discussions. So I just leave it here because I just want to show the complexity around the implantable cardiac devices infections, and that they're rarely, or on many occasions, are not really straightforward. The incidence is really unknown in the UK, and we know from the literature that it's been increasing in the US, and the expectation that it will increase in the UK as well. There are many risk factors for cardiac implantable devices infections. There are ones that really consistent with it, with the number of prior procedures, how complex it was, and if there were no antimicrobial prophylaxis given. There are a lot of other less common factors. Interestingly, the male sex or gender is a risk factor. A younger age, that was surprising to me. Anticoagulation, type of the device itself, COPD, renal impairment, and if there were any need for reintervention prior to discharge. The risk factors are plenty, but I think the most consistent ones would be the number of prior procedures and the complexity of the procedure itself. The evidence is there in these guidelines. I would probably send links to the guidelines so you could look it up yourself, but these are the most common risk factors. The mortality and risk factors for mortality, the all-cause mortality is variable between 0 and 35%, depending on the center, the expertise of the operator, and the experience of the center in doing these type of procedures. And usually the mortality is highest in the first year, and the most predictor of mortality is abnormal renal function. Also, failure to remove infected devices is a risk for mortality, and device associated infective endocarditis is a risk for mortality as well. The microbiology, I use really two comparisons. One, the one on the left side is which says table 1. This is the UK numbers, and the most common still remains the coagulase negative staph. Although it's a bit similar in Europe and Asia, the one on the right side is the European consensus, which is more endorsed internationally. The common still remain the coagulase staph followed by Staph aureus. They, however, have a little bit more streptococci. There is a bit of a difference in the rest of other bacteria. I think the gram-negative bacteria for us in the UK was a bit on the high side, and in the rest of the world was much less. But generally, still coagulase negative staph followed by Staphylococcus aureus are the most common bacteria that would cause the infection. And the pathogenesis, usually it happens by 2 ways. The first way is either the contamination of the leads or the pulse generators during implantation or subsequent manipulation. And second is hematogenous spread, basically, so lead seeding. There are various reports in the literature of how much that would be, but the risk is believed to be around 40% if there is bacteremia, particularly the most common organisms, then there is 40% risk of developing cardiac electronic implantable device infection. now the guidelines, and this this mosaic of colors is really how it feels around the guidelines of cardiac implantable electronic device infections. They're very confusing, and it's just really difficult to navigate, to be honest. And the feeling I have is whatever you have in mind that you want to do, you could use the guidelines to justify that, which is, I don't know. I'll leave that judgment for you. So I started the British not because I work in UK, but because they are the oldest one. So the current there is the guidelines for diagnosis and prevention of management of implantable cardiac electronic device infections. These were published October 2014. They are endorsed by mainly British societies. So the British Society of Antimicrobial Chemotherapy, British Heart Rhythm Society, the Cardiovascular Society, Heart Valve Society, and the Society of Echocardiography. And they came very handy at the time because there were just basically no guidelines prior to these. So even though electronic cardiac devices were in practice for a very long time, and definitely infections were an issue way before 2014. And it is sad that there were no really, guidelines to support their management. The second guidelines that followed were guidelines by the Heart Rhythm Society. It wasn't actually addressed to the CIED infections per se. They were for management for the device extractions and lead management. So they included non-infectious causes. Infection was part of these. The Heart Rhythm Society defined themselves as international, and they are based in America, in Boston. And probably Americans look at themselves as the international ones, and but they were endorsed by the Infectious Disease Society of America at the time. I think they're still published through the ITSA website through their guidelines. And then the final ones, which to be honest, I would say much more organized and easier to navigate, and more handy in terms of clinical practice, with the European Heart Rhythm Association International Consensus Document on how to prevent, diagnose, and treat cardiac implantable electronic device infections. These were the most recent one, published in 2020, February, and they were, interestingly, endorsed by the Heart Rhythm Society themselves, in addition to so many other societies, and they are more global. So they, as you can see, Asia Pacific, Latin American, the International Society for Cardiovascular Disease, the ECMID, of course, and the European Association for Cardiothoracic Surgery. I believe they are endorsed by ITSA as well, if I'm not mistaken, but that's not in the website. So from now on, I'm just going to, when I talk about diagnosis, I'm going to look at what each one of these guidelines would say, and I use the flags just to make that easy so you could follow. So the British guidance, in terms of diagnosis, they classify the infections into generator pocket infection, and this is basically a clinical diagnosis. Ideally, it's an uncomplicated localized site infection, and there should be no systemic symptoms or signs of infection, and you should have had a negative blood cultures. If it's complicated, then it would be a localized infection with evidence or lead, and this is where you start. Here you start your journey of confusion. So they call that a complicated generator pocket infection, but you will see down below some reasons where they should say and no generator pocket infection, but I'll leave again your judgment. And then they divide it to they use the term ICE, which is implantable cardiac electronic device. They divide it into lead infection and infective endocarditis. So basically, the lead infection is where the valves are not involved. So there is no infective endocarditis. That's it. And in the lead infection itself, it's either definite or possible, and it's all about symptoms and signs. There is a systemic infection basically once you get to the lead infection and the infective endocarditis. But the difference between the lead and the infective endocarditis is just really the endocarditis where the valves are involved, and in lead the valves are not involved. they don't really use a criteria, so they just it's very confusing. You could use any of these if you look at it to decide which is which. But I find them really confusing. The guidance note that the lead infection can occur with and without evidence of generator pocket infection, but you could see that it says the complicated pocket infection is they say is with a lead. So you can call it either eyes lead infection, or you could just say it's a complicated generator pocket infection if there is a generator pocket, because sometimes you get the lead infection and the pocket would be fine, but you have to remove it anyway. In terms of diagnosis recommendation, they say that a chest X-ray should be carried out in all patients. CT or CTPA should be considered, which is interesting. And if the echo is non-diagnostic. However, I think the advice again is routine use of PET scanning, if you see in the last one. So they feel happy about the CTPA or CT scan, but the advice again is the routine use of PET scanning. An echo should be carried out as soon as possible, within 24 hours after diagnosis of infection is suspected. An echo should be undertaken in all patients presented with generator pocket infection and symptoms or signs of systemic infection with positive blood culture to diagnose lead infection or infective endocarditis. They recommend a repeat echo after device removal to identify any persistent valve or mural vegetations. In terms of the microbiological recommendations specifically, they recommend blood cultures and lead fragments when it's removed, lead vegetations, if any, and generator pocket tissue, that's important, and pus from generator pocket. Definitely blood cultures before antibiotic. They recommend 3 blood cultures, specifically more than 6 hours apart, and they recommend repeat blood cultures 48 to 72 hours after removal of an infected device, and tissue cultures from pocket side. They do not recommend screening specifically for Staph aureus prior to procedures. I will look at this later in the preventative measures. Only the MRSA screening as per the national guidance. If a patient is non-colonized, they should be decolonized, and systemic prophylaxis should be used prior to implantation. And they issue recommendations about what sort of systemic antimicrobials can be used. As for the Europeans, their diagnosis is, I think, is easier to adopt, and it's just straightforward. They talk about superficial incisional infection, which is just a clinical diagnosis, definitely with no systemic involvement. And then they look at the pocket infection, so that's different than just a superficial one. And that is an infection limited to the generator pocket. And then they move down below to the systemic infection with infective endocarditis without locally. They issued a criteria for that. I think the criteria came before the guidelines. So the criteria were in 2019, and they're similar to Duke's criteria. They have major criteria and they have minor criteria. You just follow the criteria, and then you will either have a definite device infection or possible, or rejected. You could just reject it depending on the major or minor criteria. And they all based on microbiological investigations, imaging, including echo or PET scan. So they do recognize PET scan as important tool in diagnosing devices infection. Their recommendations generally are really easy to grasp. So they use this sample or symbolic. The heart green is they recommend yellow. They don't. Yeah, it's like consider if you'd like to, and basically similar really to the British ones. No much difference. The only difference is that they still recommend echo. They recommend X-ray in all patients. They recommend blood cultures. They recommend repeat echo and either transthoracic, repeat transthoracic after 5 to 7 days, or TOE if you can't diagnose trace. So they think that should improve the sensitivity of the test, and they think all Staph aureus bacteremia patients with infected or with devices not necessarily infected should have a TOE. I thought that's a really nice one that they highlighted, because I don't know if you're struggling, but we do struggle with our cardiologists to get a TOE in Staph aureus bacteremia patients. You have to like beg someone to get the echo done. They recommend the use of PET scan, and they actually they should be performed in case of Staph aureus bacteremia. If you can't reach the diagnosis from a TOE, you should do a PET scan, and they recommend also the radio-labeled WBC scintigraphy and or contrast enhanced CT for identification of unexpected embolic localization. So I think they're more generous with sort of investigations. Microbiology wise, again, it's similar to the British guidance. There are a few things that they were unsure of. They commented on the use of procalcitonin. They say it might be useful, but they don't really recommend with or against that. They specifically recommended against cultures from the sinus of the pocket, or if the device exposed. They don't really like cultures from the pocket, although the British recommended using pus cultures and tissue cultures, but for them they don't really like the sinus of the pocket if that's been exposed. They have a nice algorithm that you can use and just follow around for diagnosis of a suspected infected device. And we love flow diagrams here or diagnostic algorithms. You email someone any guidelines, they say without flow diagrams, don't send it to me because no one would look at it. And I think we became very flow-minded kind of. I myself use the flow. To be honest, I open a guide. The first thing I do is I go and look for the flow diagram because it just saves me time. And then if I needed to look at more details, usually I go back to look at it. But it's as you can see again, it's the positive blood culture or negative blood culture. That's the start, and then you do the echo. Apparently, you'll need it in all of them, and then depending on the findings, you will use the criteria to apply it. Is it projected? Then you go and look for alternative diagnosis, or is it possible? Maybe you will refer to a center where they can remove the device, and same goes for definite. If it's just superficial infection, you probably treat it conservatively. The Heart Rhythm Association, which again, I don't know if it's American or international, their diagnosis, they have really these 10 categories, which I found really, it's interesting because you will definitely have a more stricter or you know exactly what you are dealing with, so you can classify it based on these 10 ones. But in terms of management, it's not going to make you much difference. And the British say any classification that does not, I don't know if that may be an international, just the British, but the British would like to claim that any classification that does not really change your management is useless. Just don't use it. But it's really, they just have each one in separately. Superficial incision infection, isolated general pocket infection, isolated pocket erosion but not infection, bacteremia with or without systemic infection, symptom signs, and so on. So you just find, including situations where infection is not certain, like our patient, the first one, where that would fit him really nice. We think it's CID, but we were not certain really that was a CID. So that would be classification 10. Imaging, again, is similar. They think that echo is useful, and they will also pro use of a CT PET, particularly when diagnosis is doubtful. And they recommended echo should be considered for all patients, which I find nice. The British just sort of try to avoid the echo, and I do understand that because of the backlog and the delay in treatment that might result in. So they just use ambiguous language around that. Microbiology wise, they had really no specific recommendations from that side. They just really didn't mention, and I do expect that, because I think these guidance were issued by cardiologists. So it's not really infection specific. It was mainly about the devices, device management, lead management, extraction techniques, and these sort of things. So they didn't really look at that. But they also have a very nice flow diagrams. When you suspect it, again, they start with the blood cultures, same as the European ones, and then positive, negative, you do your echocardiograms. But I can see that they used transesophageal, the TOEs, rather than TTE in their diagrams, which as if they say, I don't know, you should just go ahead and do the TOE rather than waste your time and do the TE. And again, they talk about the reimplants and when you can do them, which again, from infection perspective, I'm not going to really address that. So if they were bacteremic but with no evidence of infection, they also sort of have, depending on the organism, they tell you what to do. Even if there's no evidence of CIED infection, if a Staph aureus, one of these bacteria that are known to cause problems, they still recommend device removal. And interestingly, with gram-negative and pneumococci, which are more virulent, but there is no evidence, they are happy to wait and watch. And I guess this brings us to the literature, because we know from the literature that coagulation of staphs and Staph aureus were the most common associated with CIED. So even though there were no evidence in this category, and it's a sequence repeated bacteremia, propionio, or candida, or staph, I think they thought you should remove the device rather than leave it in, while they were happy to wait and watch on the gram-negative and pneumococci. The group in the middle, the alpha hem strep, beta hemolytic strep, I have to say, I may personally feel I would disagree with them in this bit, because I think there is good evidence that oral streptococci are not really associated with devices infection. And there are actually recommendation against use for antimicrobial prophylaxis for patients undergoing dental procedures, and they have a cardiac implantable electronic devices. So, but the HRS recommends if you've got bacteremia with any of these, including the oral streptococci, you should remove the device. Or you could, I think they give you the option. You could observe. Probably I might observe. I'm not sure I would remove. But management-wise, so again, this is the British diagram. It's just, again, similar. If you've got a generator pocket wound infection, you really need to know. I think the first thing you need to know is where is this infection just generator pocket, or is it lead, or does it include the valve as well? Because if it includes the valve as well, you may need I think the distinction is important, because if it's the lead only, on many occasions the physicians only can do that, so they don't need the surgeon. So the physician can remove the infected device in a cath lab. But if the valves are involved, then usually the physicians won't touch the patient. They would need, or even if they would, if the surgeons didn't want to touch the valve, the physician may go in, but they would insist that a surgeon is present, or they would do it in a like what we have here, the Heart Institute. The cath lab is sitting next to the theater, the cardiac theater, so you could immediately intervene or take the patient next room where surgeons would be able to do it. But genital pocket infections management usually is only simple, conservative, and it is 7 to 10 days. While the lead infection and infective endocarditis are prolonged 6 weeks, antibiotics, and it just really the same as infective endocarditis. Yeah, so this is the most important one, the one usually we get involved with. Most of the initial ones, the post-inflammatory implantation, post-implantation inflammation, and even the generator pocket, the cardiologists most of the time are happy to manage it on their own. I don't know what's the practice in your centers, but really for us, they rarely call us about a generator pocket infection. They know how to deal with it. They know what to send, and they know how to manage it. They do involve us usually when it involves the infective endocarditis or lead infection. And again, very nice flow diagrams. I'm sure you will need really time when you are managing a patient to look at these and just decide. But the British are really confusing. they are very detailed, British, about what antibiotic, what is the dose, oral or IV, in each part of these ones, early post-inflammation or generator pocket, complicated, uncomplicated, or there is an ICD. And they're also very organism specific, the British. And I think they are the most detailed one when it comes to organism specific. So if you have any organism, you could just really look at options here, use them, and they are helpful. There are few things that they did confuse me, to be honest, and I just felt like I would want to maybe ask someone about it. I think it's about in the management of Staph aureus bacteria, Staph aureus particularly. I'll show you this description later. They talk about this durations as well, and how long do you need to use. I think they recommend IVs in all of these management, and I think the Europeans as well also recommend IVs only, IV management only. So and they talk about when device can be removed and no prosthetic valves are involved. They're really very detailed, the British in this one, very, very detailed. Once you have your diagnosis and you're set, you just need guidance around management, antibiotic choices, you will definitely find something there, definitely. As you can see, it's just really very, very detailed. I'm sure you will. That's really difficult to go through, but if you need a specific bacteria or anything, they will definitely have talked about it, and you can find it there. There is some difference in Staph aureus regimen, and it's basically when device when there is no prosthetic valves, and device can be removed, and between the device cannot be removed. I think there's just the add of gentamicin, which I really found difficult. I would accept the rifampicin, but the gentamicin made me for the Staph aureus management of MSSAs. Maybe I'll hear from you after the talk if anyone would have an explanation. Is in when device can be removed. I know for rifampicin, it's got a antibiofilm activity, it penetrates the biofilm, but it gives you the option of gentamicin for the MRSA when device can be removed. For MSSA, it asks you to give it. I think it's just the historic guidelines of infective endocarditis when we used to give gentamicin for staphylococci, which I think we've moved from this recently. But that's the main sort of difference or comment here. Even if you want to salvage the device, they didn't really recommend longer, it's still just 6 weeks. You can switch to oral antibiotics for generator pocket infection after device removal, but they insist that IVs all the way for infective endocarditis, or if you attempt to salvage the device. Again, the duration, depending on the type of infection or whether you have any other complicated infection like discitis, you should consider extending the duration. They note that. Yes, I agree. I thought that would be their reason. Yeah, and it is all these guidelines in 2014. So at that time, I think we were still using that. I know probably now recently we're moving away. So maybe I couldn't pick that. And if salvage fails and patient unsuitable for system removal, long-term oral suppressive therapy is recommended, which like in our first patient we used. The Europeans, though, it's way simpler, to be honest, than the British. So for a quick navigation, and they are the most recent one, you could really go head to the European. You could quickly use their 2019 criteria to decide, is this like definite or possible or rejected infection, and then just use your options way shorter, and they don't really they don't go into greater details like the British did. They just note for the most common bacteria, but they don't really do it in the same detailed way for almost every organisms with oral options and second lines and allergies and all these kind of things. Way easier, way simpler, and easier to navigate. They go into options as well, but it's a bit broader than the British would use. We don't like really cephalosporins easily. I don't know, but they use it. In terms of preventive measures, the British, it's really, again, the same. They recommend a specific setting with air changes recommendation, and they comment on the operator, and where possibly they advised against use of temporary transvenous pacing prior to reimplantation. Not just implantation, and that it should any elective procedure should be avoided if there is a systemic infection. And in terms of the screening, I don't know what's a practice in the UK. They recommend, they say there is no investigation for pre-procedure screening specifically for cardiac devices. They recommend only to follow the national guidance for MRSA screening. I know our center screened for MSSA prior to procedure. That's what we do locally. It's not really the national guidance. They have some advice about anticoagulation management. They talk about theater measures, skin preparation, wear in theater. It's really nice and detailed. If you want to commission the service and ask you to give some, recommendations, you can use these guidelines really nicely. They talk about antimicrobial prophylaxis, systemic timing, and agents. They give really good details. And they recommended against the use of local instillation of antibiotics. I think they commented that it should be avoided pending further evidence, and they were in 2014. And I believe still in the European guidelines, it's a similar comment, so that the local installation should be avoided. So I don't know if you practice anything differently. The HRS, in terms of prevention, they have a nice diagram. I think they yes, that's European, sorry. Yes, so they were not really detailed on this, but it's a similar, they didn't issue recommendations specifically, but they have certain comments about, again, avoiding the procedure during systemic infection, use of antimicrobial prophylaxis, skin management, and again, they commented against that. They commented there is no evidence of antibiotic irrigation of the area where the generator pockets will go. They commented, however, about the use of non-absorbable antibacterial envelope, and they said that it showed some promising results. They were close to the British guidance. The British didn't comment on the use. I don't know. We don't use it. I know in our center we don't use such antibacterial envelopes. I don't know if any of you use it in their centers. The Europeans, again, very nice flow about modifiable and unmodifiable risk factors to prevent the infection and how you can address each one of these. But again, they really just the same things. They go, however, about a little bit more details about when you classify the procedure as higher risk, so you have a heightened sense of suspicion for future infection, and maybe do more follow-ups or more regular follow-ups, because as we said earlier, the highest risk is in the first year post-implantation. Again, in red and green and yellow, you could just quickly see that, again, temporary pacing should be avoided, which they agree. And they just added one thing, is that the replacement device on the same swim extraction side, they recommend against that. Again, it's more of a technical issue rather than mic or infection problem. They commented about the use of novel devices that should be used in selective patients, but again, that's outside our scope, maybe a little bit. They commented really nicely about the experience of the operator, and that this is really something, as we said, one of the most consistent risk factors for infection. And they felt that this should really be addressed and looked at. there is some about the pediatric and congenital heart disease, so they have a special comments about this. But again, I do mostly adult. Maybe our colleagues in pediatrics or those in centers where they do adult congenital heart disease could comment further if they would use any specific guidance. Exceptions. So these guidance, as you can see, they're really nice and very exhaustive. They cover the most organisms. But are there any exceptions? Now this case series by our esteemed colleague, Dr. Fathi Zain, I don't know if he's here with us today or is still here. They looked at brucella infection of the cardiac implantable electronic devices. So their center in Riyadh, Saudi Arabia, these are like 15 patients, and how they diagnose them and what sort of regimen they use. And to be honest, I'm astonished, or I'm surprised, I'm amazed. I think kudos to them. They almost cured. I think this is really very high, very good management of cure. I mean, brucella without a cardiac device infection would scare me, particularly if you look at the titers, how high these are. But they managed them really nicely, and almost the regimens were consistent. I think they could really issue guidance almost based on this. I know the sample number is really small, but even for brucella, that would be decent. And what type of devices they had, and whether it was primary or secondary prevention, which side, and whether they had reimplantation or not. And interestingly, the majority were few years after the implantation rather than long. So with the exception of these two, 13 and 11, the majority were like, and it makes me wonder whether these patients had brucella to start with, and then the device came in later. That's why it got infected. But anyway, difficult to tell. So yes, I think particularly for those of us who work in the Middle East, the guidance do not cover important aspect or things like brucella, but we do have experts here, so maybe you could shout to when you have any queries. And that's it really. So we'll be happy to have any questions or comments. Please join.
Thank you, Mustafa, for the excellent presentation, and the floor is open for any questions. Thank you again.
Right, turning 10 lights on.
Yes, Ahmed, go ahead.
You guys can hear me?
Yeah, now can we hear you.
Thank you, Mustafa. Thank you for taking time and to prepare this review for cardiac implanted infection. You know, it is really very difficult topic to navigate, and I think you did navigate it very well. I think some of the question I have is Mustafa, did you like the role of sorry guys, this is my son up here today.
Yes, all right.
So guys, someone can take another question. I will be back in a second. Just a second.
No worries. Yes, Yusri, go ahead.
Hey, Mustafa. Very nice, very nice. I always wanted somebody to review this for me. So, really good. The two questions. The first case you presented, if you asked if we would have done something differently, I probably wouldn't have done anything differently. But I'm just asking about the rifampicin in the light of the different guidelines that you presented. Would you, if you had a chance again to do that again, and how would you read that with the the resistance profile that you've seen on subsequent cultures? So it's just always a question for us: do we add RIF or we don't? So that's the first one. The other one is just a comment about the 2014 guidelines. I think the PET scan not being recommended is a typical just NHS thing, because the procedure wasn't widely available at that time, and they were probably worried about time and money. But I'm glad that everybody else now is really recommending that.
Yeah.
Thanks.
Yeah. Thank you very much. Thanks. With regard to the rifampicin question, that case is really different. I think it's a bit easier now in retrospect to judge. So in retrospect now, I know that he had a device and that there was a possibility that the device might not be removed, as the surgeons were really reluctant, so were the physicians. So he would fit into the guidelines that this should be used, rifampicin, for device salvage. However, at that time, because we had no evidence, to be honest, we had no evidence guidelines-wise, we had no evidence to justify using or adding rifampicin at the time, because his TOE was negative. He would have been possible though by using the 2019 criteria, because he had this consistent bacteremia with an organism consistent with the infection, but he had no imaging supportive of that. And he had all other markers like fever. He had the PE, which would be a vascular phenomenon. So he would have had one major and maybe two minor. So he would be at least possible, but you could argue that he could be major as well. So in retrospect, you would say yes, but at the time we didn't have sufficient evidence to use the rifampicin. Had it made any difference? Again, in retrospect, no, it didn't. And it brings us to sort of the importance of source control. We all know that. And the problem is, I think, I'm not sure really if the cardiologists or the surgeons do reflect on such cases, that had they removed the device earlier, this gentleman would have, stayed, if you look at his quality of life, that's affected for all these 9 or 10 months. And then eventually he had to go for the procedure. And he then developed complications with the impairment, prolonged the stay. I think they need to. We know that because we took this guy's been to the MDTs, infective endocarditis MDTs, at least 3 or 4 times, and they will rebuff us every time. They'll just say no, they look at, he's very well. No, we're not. It's not that, you got it wrong. But anyway, so yeah, I guess in retrospect, yes, we didn't have the evidence at the time. In retrospect, yes, he may qualify should we know that he will carry on. And the more difficult question is whether we had a similar case again, what would we do? Would we do anything differently? Would we add the rifampicin or not? I think I would make it clear. But the problem is the surgeons at all times will say salvage the device or keep it. They don't want to do the procedure to remove it, particularly if they are well, unless you tell them they have these flying vegetations. In anyone who is well, they will say, yeah, that's fine, carry on. Yes, Ahmed, please.
Yeah, sorry for that moment.
That's okay.
So I think one of the questions is did the guideline put any suggestion regarding the suppressive antibiotic, the choice? This is
yes, British did. The British one did. The British chose. They give you some options.
I see. Like, is it Bactrim, Doxy, or they come up with?
Yes, Bactrim, Doxy, Clinda. They give, depending on the organ, but they give amoxicillin in case of enterococci that are sensitive, or streptococci, if they ever be. But the British do, in terms of choice of antibiotics, duration, and even the mode of delivery, they were really comprehensive, and they cared about the details.
The second question, I think part of it was Dr. Yusri said about the rifampicin. The use of rifampicin is like usually after clearing of the blood culture, fearing resistant. I did recent review on the adding rifampicin even for prosthetic valve endocarditis. The data behind that is very sketchy. Like, I think it's very small trial.
300%. Yeah.
And the other part of it is the dosing of the rifampicin, how much you use. And if you ask many physicians, they usually use maybe 600, but if you look carefully to the guideline, they are using up to 1200.
12, right.
And I'm not sure how much you can use, like 600, 1200. I haven't used it. I think most of have used maybe 600 or 900. So this is the second question. Your comment on the rifampicin.
Thank you very much. Yes, rifampicin is real. I think I'm not really sure it works all the time. I think the majority of cases would have been source control is the main thing. There were occasions where the rifampicin worked. We do use the 1200 and we use 900 sometimes. when we are targeting staff biofilms. So we have been using it. Some of us might just use the standard 600, but definitely we've used 1200 in our center. We use it in PJIs as well, prosthetic joint infections, with a lot of rifampicin there. And we use the high dose because I think we just feel like we can use it because the joints are big as well. And most of these patients the look at is they will not go for surgery again. No surgeons will touch them. They have no options. So you just really throw everything with the highest possible. We find it easy, to use higher doses, and it has been fine for us. But I agree with you. I think it's one of the things that eventually in the future, the guidance or the recommendation for when to use it and how to use it will be tightened, will be more stricter. Rather than now. I think now it's just mentioned you can add it or consider adding. And with regard to the timing, yes, I think it says 10, 12 days. Most of the evidence is the best is when you add it after like 10 days if you clear the bacteremia, or if you are going to do debulking or some removal or washout in some, so if you're doing a DARE or any of these procedures where there is a prosthetic that would remain in situ after that. But to be honest, we have a difference in opinion amongst our team. Some of us just feel that the evidence for that is not really, to start with, is not great, and they would add the rifampicin as early as possible. They don't really worry about developing resistance as long as you're using second agent. And some of us just really follow the guidance strictly and just wait maybe for 10 days, 12 days, and then they add the rifampicin.
Yeah.
Thank you, Ahmed.
Sorry, I have another more one question.
Yes.
Those are the difficult one that's coming, and this is what we
Go.
have seen here in US sometimes. Mustafa, if what we have seen, the people that they are become above 80, above 90 with this cardiac implanted device. If you see they become very skinny, and the pacemaker itself is almost eroding the skin because of there's not much left muscle. So lead erosion.
Yes.
Like with I'll tell you the practice here. Like whenever I see lead erosion, I say just take it. There's no way around it. Take it, put a new one. And what we have seen, what we have noticed now, they are using this leadless device.
Yep.
They go into the other side. So I don't know what is the guideline, because it didn't mention anywhere like
none
erosion.
None of the guidance.
This is just the old population that we've seen here in US.
Yeah. So the HRS, the Heart Rhythm Society, the one that, it's a guidelines that were published in 2017, which it's American society, but its membership is international. Really, anyone can become a member. They are the one who had this classification, lead erosion. They just put it like that, lead erosion, with or without generator pocket infection. Right. So they have a lead erosion as a separate entity. However, they don't really go into details on how to manage that in terms of antimicrobial management or antibiotics or what to give. And because the HRS just really address the lead management and the generator pocket management, they don't necessarily, as I said, the infection comes as part of their guidance generally, but the guidance is not really addressed for infection. So for these ones, they talk about lead removal. And reconsideration, so re-referral for consideration of, do they need insertion? Do they need a device reimplantation again? Should remove the lead if it's eroded, and then reconsider the indication for a newer pacemaker. But none of the other guidelines really talked about lead erosion per se as a separate entity.
And Mustafa, the last question is about and we've seen this here in US a lot. If you have someone who had pacemaker or let's say even prosthetic valve, in the presence of bacteremia from other source like UTI, pyelonephritis with bacteremia, is there any recommendation, knowing that the sensitivity of transthoracic echo is in presence of prosthetic valve or pacemaker is maybe only 30%.
Yeah.
And with
Yes.
transesophageal echo, you're getting into 80 in the presence of those. So without evidence, the question is without evidence of pacemaker infection or no sign of endocarditis, in the presence of a pacemaker with bacteremia from other source, is staph or other gram-negative, would you do any cardiac image? Is it like, even if you said yes,
Yeah.
echo TEE, echo sensitivity is 30%, how you approach that?
Yeah, so the Europeans were the best really to address this issue, the European guidelines. So the Europeans say all Staph aureus bacteremia patients with a cardiac device, implantable cardiac device, regardless of the source, they should get a TOA. So that's their guidance. Whether there is infection or not, they should get a TOA. And if the bacteremia persists, they recommend repeating an echo, or they consider repeat the TOE in the future. And even at this point where you do a white cell label scintigraphy, PET scan, or a PET scan again. And even if you have high sense of suspicion that device may be infected, they say remove the device. And in bacteremia without identified source, for Staph aureus, coagulase staph, propionibacteria, and candida, they say the device should be removed. They want you, if you have no evidence of vegetation, no evidence that the device is infected, but you've got a bacteremia and no evidence of infection, no evidence of a source of an alternative source of infection, they say remove the device. And they give you a consideration to remove it in the alpha heme strep and some other, the enterococci. And they were a bit friendlier in the gram-negative and pneumococci. But yes, the Europeans talked about this particular area, Ahmed. If you have any of these patients, and if you look at the European guidelines, you'll find they give you really good cover. I think they almost cover every scenario in these cases. And it's mostly like, it's just remove it. The European, I think, are really good. I think I'll move to use I have been using the British most of my practice. I think we just get used to them. And I've only digged at the European in depth for this review, but I think I will just shift now. Good luck for me convincing my colleagues.
Thank you, Mustafa. Thanks.
Thank you, Ahmed. Thanks. Okay, thank you, everyone. That was really handy. Thank you for giving me this chance. And I look forward really to see you again shortly.
Thank you, Mustafa, for the excellent presentation. We really appreciate your time, and we hope to see you all next month, inshallah. Same time, 9 Central.
Inshallah.
Thank you.
Thank you.